Good morning. Thank you very much. I'm Evelyn Tomaszewski. I'm a member of the forum, and I actually just have a very quick question for Dr. Yan. I was looking at your slide on legislation and intervention efforts. Could you clarify what is meant by long-term care insurance plans in Japan and how the connection?
The long-term care insurance plan is actually, well, on one hand, it tried to make sure that an older person got properly taken care of. So it has to do with health insurance. It has to do with people getting properly supported financially. And then part of it has to do with elder abuse. It made it mandatory to report elder abuse. So it is a combination of different things related to the welfare of an older person. Thanks.
Any other questions, please?
I'm Jackie Campbell. Ron, I was really interested in the social support theme, and I know from research with domestic violence that we have found social support consistently related to domestic violence. But sometimes because the perpetrator is purposively keeping a victim isolated and purposively keeping the community out, so that when you do general community increasing social support, that may not be useful for that particular family where there's abuse. We also have found that it also depends a lot on how you measure social support. That oftentimes when a victim of any kind of abuse is talking about support, even from the community, they tend to put it through the lens of that the quality of support they're getting is not very useful. And especially with partner abuse, for instance, even though they may have a lot of contacts with extended family, they find that that extended family is not helpful to them around the notion of abuse, or is not anyone that they feel like they can confide in about the abuse. So, sometimes when we think about how to increase social support, we get confounded with these kinds of issues. And I don't know if you folks see that in your research, how you measure the social support and how you think it may operate.
Well, I have a tendency to be concrete, and so we emphasized instrumental aspects of social support. We did ask, do you have somebody to talk to, but the main predictor is, do you have somebody to help you when you need help? Do you have somebody to confide in? And you're absolutely right. If a person is purposely isolating another person so that they can perpetrate, that's going to be a problem. And if the social support, if the way you view social support is diminished after you've been abused, like, boy, am I really isolated, then you have a chicken and the egg, which is happening first. But Sandro Galea is a real good epidemiological interventionist, and he and I were arguing because as a clinician, I want to treat one person and have a very large effect. And his point that he persuaded me many years ago that with a very strong thing, he said, I would rather help 200,000 people 1/10 of how much you're helping those 10 people. And community-based interventions on the web, structurally, transportation-wise, have the capacity to do that. So, using the Vegas term, the Vegas mentality, that we won't be right every time, but the odds are that if we enhance community integration, I think specifically through transportation, but that's just one angle, that will probably prevent some elder abuse and elder mistreatment, and will probably, in the context of elder mistreatment, prevent negative mental health outcomes and hopefully negative physical outcomes. I think that further research, though, would help us with exactly what you're talking about, specifically what types of social support are useful, what types aren't, and how can we amplify those. But I think in general, when we talk about the population as a whole, addressing isolation and enhancing social support and community integration will have a two-pronged intervention effect. One, it'll prevent the elder abuse, and two, once elder abuse or mistreatment happens, it'll limit the negative consequences.
Hi. I was thinking about what you were saying, and I think that it's very, very difficult to stop people abusing if they really want to abuse. But I think that's probably a relatively small percent of people who really want to abuse. If you change society through transport and so that isolation is abnormal, then actually they begin to be flagged up as people who are in danger. Whereas if isolation is normal, then, and it's just like, well, all people's friends die, then nobody really thinks anything of it. If it's abnormal, then we might begin to get to these people as well. But like the ward I was talking about in the beginning, if people drop in, those people who are doing it on purpose are much, much more careful. And for those people who aren't doing it on purpose, but are doing it because they can't manage themselves, they're seeing too much of somebody who irritates them, that person is behaving in a difficult way. Actually, the social support helps both parts of the partnership. So I think it will be really useful. But whatever you do, you never ever solve everything at once. And I think that community transportation is really interesting. In London, up until now, but there's talking about taking it away. When you reach 65, you get free public transport, and it's not 101 degrees. And I'm sure that, or anywhere near, I'm sure it saves a fortune, and that thinking of taking that away is a very stupid idea, because people at 65, most of them are pretty fit. They keep going out and taking buses. They're not socially isolated. They remain physically fit, and currently they're not allowed to use them during the rush hours. It doesn't really affect everyone else. And it just seems to me that these sorts of interventions make a huge difference to the health of the whole population in a relatively simple way.
I'd like to make a comment on this, because when we started the movement that is now global, and we have 1,200 cities that have embarked into the WHO age-friendly cities movement, the original research was done in my district where I was born, Copacabana in Rio de Janeiro. And all the people there said that they had friends, the doormen, they live in apartment buildings. So that person who is there not only to help with carrying, shopping, or changing the bulb, but really monitoring. And very often that person can be the person who could identify incidents of elder abuse. Not family members, but a total stranger, and now we are training them, including, so that they can become age-friendly doormen, and including tips on how to identify elder abuse. But they have also identified, which is very important, that the enemies, if they had the friends, the doormen, the enemies were the bus drivers. And these are the people that are in direct contact, providing services, and very often don't respect, don't wait for you to sit comfortably, don't stop. In Brazil, public transport is free after the age of 60, and the bus drivers are under pressure from the bus owners, companies, not to stop if there are too many older people. More interesting, other adults are in a position of power. They consider that they have more rights than those that don't pay. And therefore, those that don't pay and are taking time to get into and out of the bus are a nuisance. And therefore, they end up being abused. And the intention at the beginning was correct, to provide more opportunities for people over the age of 60 to use public transport, and therefore to fight social isolation, are very important risk factors that we heard from all the different speakers giving this global perspective on aging. But you end up being abused because you don't pay. So how complex the whole situation is, and with an incidence here of elder abuse in practice in the community. I'd like to ask people that are around here And if you have a comment on a new frontier related to social isolation, it is a group that is at high risk and increasing throughout the world. I'm talking about an area that has been very little explored in terms of research, aging of migrants. And in this country, next door to Canada, we have people here from Australia and from Europe. We have about 250 million international migrants, legal. We don't know the number of illegal immigrants. And these are the people that don't have the family next door to protect them in relation to elder abuse. And I would like to know if you have any comments in relation to this important pool of aging individuals that are at high risk from social isolation and therefore from elder abuse. Please.
I think in mainland China,
Identify yourself always,
I'm
please.
Michael Phillips from Shanghai. I think in mainland China it's a little different. It's all the young people are going to the cities, leaving the old people alone at home, and it's not really abuse, but they don't have the traditional family support available to them, and so it's got a different. It's not the old people migrating; it's being left home in the rural areas, which makes it a different pattern.
Of migration, those people left behind when they were expecting, and very often it's just compounded by the fact that their children, that are the migrants, don't have the financial support. They are unemployed, they are not doing well, and you don't have either the physical support or the financial support to these older people.
We're beginning to talk in mental health quite a lot about ethnic density, and migration is not simple at all. I mean, the people who migrate because they are economic migrants, and they're usually the most entrepreneurial and successful of people. And there's other people who migrate because they're persecuted, and they're running from where they are, and they're quite different, and their experiences are different. But if there's a whole community that migrates together, they tend to stay together, and they actually have extremely close social links and often look after each other better. So I think you don't have to, it's not where you were born, it's the density of other people like you around, and these people may not be ethnically the same as you, but they tend to be. I mean, as we get a more diverse society and there's more intermarriage, that becomes less so. But currently, it's how many people are around that are like you. But ethnic density currently predicts increased schizophrenia. So if you have low ethnic density, then migrants are more likely to develop schizophrenia, and higher ethnic density protects. And you can imagine that if you're the only, and there are places in Britain where you're the only person who is not white walking around, you think everyone looks at you because they do. And if you've got any tendency towards paranoia, it's increased all the time as you walk down the street. So I think it matters, who's not just where you come from, but who's there.
I know what you mean. I lived in Britain for 20 years. Could you please?
Right. I wish to follow up on the comments about younger people in the PRC moving into the city. So in fact, we have instead of older persons being left alone, we have lots of skip generation families where the grandparents actually need to take care of younger kids, relying on very, very little resources they have. And related to that, is about like the changing social dynamics. And I want to relate it back to questions raised by Professor Campbell. While transportation may not be an issue in Hong Kong and in most of the large cities in China, because we're fairly close to each other. It takes about 1.5 hours to travel from one end to another end, and with very good public transportation. But the thing about all these fairly well-developed or advanced cities is that we're pulling down all the old buildings. So older persons who used to have a very good social network in their places, while we pull down the buildings and build up new ones, we relocate them. And they lost all the social networks that they used to have. And that's the major issues for us.
They get a much nicer apartment, but it's often a 22-story building where they don't know the next door neighbor.
things that were just said. Geez. And so one, I would say, anecdotally, I was in the Czech Republic several years ago trying to help them with, along with Sally Hermy, to try to look at issues related to elder abuse. And I did witness just what you said, which was an aging in place of the older adult population, but both an outmigration of the younger populations as well as a younger population, which was so technologically savvy and so much more entering the workforce in those particular realms that the older adults were left somewhat out of the faster pace of that society as the changes were happening. Secondly, to your issue of older adults who migrate because of economic or political hardship, I would echo the issue that I've worked with Dr. Tenzin Wangmo on Tibetans living in diaspora and older Tibetans, both in India and Switzerland. And the same issue took place as you spoke, that they tended to stay very insular in their communities, and so provided a protective approach or protective factor to some of the abuses that might happen if they were not in an insular community.
If people from the audience want to, there's microphones back there, those two places. So if you want to go to the mic, there's a microphone back there. It won't get picked up. Sorry.
I just wanted to raise, Laurie Krieger from the Manoff Group and George Washington University School of Public Health. And I wanted to bring up the, to echo something that was said, but to expand it. And that is that the issue of HIV/AIDS really impacts older people throughout the world. You have usually grandmothers taking care of little children with very limited resources and very limited ability, sometimes physical ability. And also to say that there are some studies, I'm not an expert in it, unfortunately, but there are quite a number of studies of migrants, certainly in the U.S., but there are anthropologists, and there aren't any anthropologists on this panel.
Any comments? Please.
Linda Kincaid, representing the Congress of California Seniors and also from the Berkeley School of Public Health. I am very interested in the things you're talking about, the data you're presenting. I think the data that you are presenting speaks against a trend that we're seeing in California, where the court system is taking the most vulnerable, largely people with dementia, out of their homes and placing them in facilities because it is easier and less expensive to manage these persons in those situations, where they tend to become isolated from their families. Sometimes they're isolated from families because it's just difficult for a family to go visit them 30 miles away, across town. Maybe there aren't visiting hours when the person is off work. But we also are seeing instances where the court is deliberately restricting the visitation of the family because perhaps the family agitates the person. Perhaps there's some history that may be questionable in the family, but I think your data would indicate that even if that family member may have a questionable history, it's still hugely important to have that social contact of someone who knows that person, sees that person regularly, and cares about that person, and also to represent their interests. And I would perhaps like to speak with some of you further about this later.
A Xingqi, forum member. Yeah, where to put the knife? Okay, we hear a lot about the prevalence differences depends on how we categorize things. I mean, as a clinician, as a practitioner, you know, we're trained to give diagnosis, whether you have it or you don't have it. Much of life is anything other than that itself, whether it's dementia or cognitive impairment. So for the field of elder abuse, as a researcher, where should we go from here in terms of understanding the incremental issues relating to elder abuse? How do we, is this where the field should go in terms of using those different cutoff points? You know, how do we inform policy based on such various cutoff points? How do we design interventions, understanding risk factors based on those different cutoff points? I would hope the speakers can comment on where do you go from here in terms of getting prevalence and the incidence estimates based on such a wide range of numbers that you quoted.
Before I ask the speakers to comment, there is an intervention that you seem anxious to, please. Go on.
Me?
Yeah.
Yeah. So my name is Erin Sanabajo. I came from Mongolia. I do work in health sciences of university in Mongolia. My question might be a little general, but maybe too specific for a special group of people who find themselves in the position like me, who are doing a proposal, trying to write a proposal in the research. So, because there are the screening tools, the research methods in the elder abuse field is just enormous. So how do people, how can they develop their proposal so well that it really captures the phenomena culturally consistent, reliable, valid, and in terms of the research designs, like qualitative versus quantitative, or original versus available data use. And so what is your primary advice, I would say, as you commit yourselves in the research field?
I would ask anybody that could help you to guide you into this, to make contact over coffee breaks and lunch.
Oh, yeah, okay.
Because we would like to address this very important point that Chinky Dong has asked the speakers to comment.
I'll comment to both. I'd be happy to talk to you. The first step is to look at what's already been done on the big studies and then try and adapt it to your culture, I would think. Well, the definition and the remedy is going to be dependent upon the conceptualization of the problem. And we weren't supposed to talk about that. We just talked about numbers. But when you talk about cutoffs and when you talk about what is it now, what do we do, or where do we put the knife, it's going to be very important to approach this either. If you're a general practitioner or a neurosurgeon, you put the knife in different places. If you're a general practitioner, you're probably going to try medication and lifestyle change before you start to cut. If you're a neurosurgeon, that's not what you're paid for. So what we're talking about, what I tried to emphasize, and I'm going to try and push hard again, is one, there are two elder mistreatments. There's elder mistreatment against cognitively impaired, non-independent elders, and there's elder mistreatment against community residing older adults. That second one, because the domestic violence level and because it's violence against independent adult by independent adult, should be conceptualized like domestic violence, and the knife would be put in a place, and that's probably now at this point not the best analogy to use, but I'm continuing with your thing. I know you're doing it from a medical perspective, but switching back to a violence perspective, when you have a domestic violence conceptualization, what your remedy is and what your intervention would be is going to be very different than if you have a child abuse conceptualization, which is an non-independent, unempowered individual being abused by an independent, empowered individual. That fits better with the institutionalized older adults. I don't think we need to reinvent the wheel. I do think it's very expedient to borrow from those two fields and apply the things as they need to be applied. One, the domestic violence field to the independent residing elder mistreatment victims, and the child abuse field to the others. Now, or institutionalization field. For example, you would not have the staffing in a juvenile delinquent facility that you would in an elder adult nursing home because you'd have tremendous violence. Guess what? When you have that type of staffing and environment in that type of institution, you have tremendous violence. So that might be an environmental remedy, very different than what you would do in society among people who our data are showing, heck, about half of the physical violence, more for women, is spousal abuse, and the rest is other people living in this. That's domestic violence. So really, where you're going to put that knife or where you're going to put that money is going to depend on how you conceptualize the problem. And that really turns on whether or not the person is cognitively unimpaired. So when we have elder mistreatment conferences, I still don't see that separation to the extent that I think we need it.
We are approaching the time for concluding. I will ask the two last speakers to make very brief comments. I am aware of other comments, but I'm sorry that we have to keep an eye on the clock.
Okay, I agree with Ron. I think the difference is whether somebody is competent or not competent to make the decision to accept it. There are adults who live in domestic violence and they are competent. They may be cowed, and terrified, and we can learn from the domestic violence field about how to deal with it. People with dementia generally live in the community, but they're not able to make informed decisions. And I think it's really helpful to look at child abuse. I mean, clinically, people keep saying to me, you know, this son isn't abusing his mum. He locks her up all day when he goes to work to keep her safe. And I say he may not be abusing him in his head, but he is abusing her. It is, you know, you would not leave a 2-year-old all day locked up because they're not safe to go out. And she is being locked up because she cannot do things for herself, and she can't walk in the street, she can't make phone calls. And we have to use it from there and take away from the intentionality of what the person does to what they are actually doing. And I think it then becomes clearer, but there is a societal educational thing which people are doing and which has been talked about particularly over the last year, where we have to understand what is unacceptable way to treat somebody who is not competent to look after themselves and not able to complain about it.
I second my colleagues in that I too believe that people with cognitive impairments, they should be looked at differently from people who are cognitively intact. And then I think the major issues for us is for older persons to acknowledge their own rights. As I mentioned, like lots of older persons, they do not understand what elder abuse is, and they have very blurred idea as to it is their rights to live independently, to live without elder abuse. So that's my.
Thank you. Well, I do apologize. I understand that there were other questions that would like to be posed, but we have to keep an eye on the time. We are talking about vulnerability. I thank the speakers to give this global overview. It is a very complex issue. We are looking at vulnerability. We are on the verge of seeing a major increase on people that are particularly vulnerable because they are 80 plus. It is the age group that is going to increase fastest in all societies throughout the world. They are particularly vulnerable of social isolation. We are seeing throughout the world the trend towards nuclear family in Asia, in Latin America as well, in developed countries. And just to give a figure, if we have 800 million older people in Asia alone within the next few decades, in 3 decades, and if we would get this ballpark of 5% of them being abused, we have 40 million cases of potential people being abused. So we're talking about big numbers, and there is an initiative by WHO called Age-Friendly Cities. And I urge you to look at the website of WHO, because the idea of age-friendly cities is from a multidimensional perspective to tackle on all the issues that we are talking about here to protect people from elder abuse. There will be more and more older people, especially in urban areas, because these two trends go hand in hand. More older people living in urban areas. We'll have a break now for about 30 minutes. Please come back on time for the next session. Thank you.